Hi, A.Holden here. It's a pleasure to join you for this session. What's new and interesting in vascular access? Quite an interesting session, and these are my disclosures. We know that vascular access requires a access life plan, and really that includes the method of renal replacement therapy and the maintenance strategy, and that may be updated. We know that in terms of maintaining vascular access, that endovascular treatments vary in terms of whether they are irreversible or not. Certainly covered stents and bare metal stents are permanent implants. Angioplasty and DCB are not. Now, this interesting publication by Vasharajani and colleagues recently looks at new technologies in vascular access. And I want to focus on a couple of points. And of course, the first is drug-coated balloon angioplasty. This recent meta-analysis clearly shows a significant advantage for drug-coated balloon angioplasty over standard PTA in terms of patency of the AV access circuit. And that's really contributed by the Medtronic Impact AV Access IDE trial, which right throughout its follow-up time points has shown a patency advantage for the DCB over standard PTA. Quite a different appearance to the Lutonix randomized control trial, which not only had lower patencies, but lost its patency advantage between the two treatments in the follow-up out to 2 years. And while we know this information, and I'm going to present more in detail later on in this meeting, one thing I want to focus on is some new data on access circuit thrombosis. We know that this is a very expensive event, that patients who get access circuit thrombosis have much greater costs for treatment. We know that revascularized access circuit, once it's thrombosed, it has a very poor patency, 10 to 25% through 12 months. And unfortunately, we know that the occurrence of access circuit thrombosis harbors very poor mortality, much higher all-cause mortality than patients with a patent access circuit. So it's very interesting. Over the years, we've been looking at the Impact AV results in terms of access circuit thrombosis. Previously, we've seen the trend of a lower circuit thrombosis rate for the DCB arm. Now at 3 years, it reaches statistical significance. And given the morbidity and mortality associated with access circuit thrombosis, this is a very significant finding. But while we can see clearly that DCBs are efficacious, are they cost effective? That is the upfront cost of the DCB offset by the cost of lower re-interventions? And if so, when? And does that apply to all health systems and geographies? Well, the study that's really looked at this is based on the 12-month data from the Impact AV study. This was published recently in the Journal of Vascular and Interventional Radiology. And this obviously showed a very good patency difference between the DCB and the plain balloon, but also a significant reduction in the number of interventions that were required to maintain patency. The number of re-interventions reduced by 35.4%. And so this really is the basis for looking at the economic implications of the DCB versus PTA. And first of all, this has been studied in the US, and again, published recently in the Journal of Vascular Interventional Radiology as a paired publication with the patency publication, looking at the patency through 12 months and studying two approaches. One is the number of interventions to maintain patency, and the second one was the patency difference between the two arms of the trial using Medicare data. As you can see, the conclusions are that if a cost of $1,800 is used for a DCB, then using the approach one, the number of re-interventions, break-even would occur at 2 years, and using the patency difference, a break-even would occur at 1 year. So we can see, if we compare the primary patency between the standard PTA and the DCB arm, that we can see at 12 months, there is a significant cost saving and an even greater cost saving at 30 months. And we can see the same trend in different populations with different health systems, such as in Germany, where you can see at 1 year there was a saving of more than $1,000 euros per patient, and at 3 years, a DCB strategy would save 3,000 euros. And again, here in Japan, where you can see initially the upfront cost of the DCB meant it was more expensive, but after around 30 months, there was a cost saving for the DCB arm. Now, another interesting point is that both the IMPACT AV randomized trial and the Lutonix randomized trial both required pre-dilatation with a high-pressure balloon. And current high-pressure technology really tries to overcome resistant stenoses by dilating to high pressures, but these can lead to complications such as dissection, restenosis, and rupture, particularly due to overdilatation of the adjacent normal segment. Older generation high-pressure balloons are also higher profile with problems with delivery and device removal. So I want to discuss our early experience with the Boston Scientific Athletis balloon, a very different type of balloon. This braided design means it's a non-compliant balloon, so it has improved dilatation efficiency compared to high-pressure balloons. In fact, a 44% reduction in compliance compared to the Conquest balloon gives it much greater dilatation efficiency at lower pressure. It also means the device can be designed low profile, and that improves its trackability and removal and crossability. It's an 035 guide wire compatible device available in a range of diameters and lengths, as you can see. First case done in the world was a 56-year-old female with a brachiocephalic AV access and restenosis of the cephalic vein. Previously required dilatation to 30 atmospheres with a high pressure balloon. Here is the restenosis in the cephalic vein, sized by QVA to just over 6 millimeters, but it had previously been treated with a 7 millimeter balloon. So we used the Athletis balloon, and you can see as I'm slowly dilating up here, very low pressures. You can see that at around about 8 to 10 atmospheres, we got the balloon fully effaced compared to 30 atmospheres with a high pressure balloon. We then used a drug-coated balloon and had an excellent result. And we found, in fact, the patient was much more comfortable than with a high-pressure balloon. We then looked at 15 patients who had restenoses treated with high-pressure balloons, then treated with Conquest. All patients reported much less pain, and they had much greater dilatation efficiency, lower pressures, and a lower residual stenosis. So certainly the Athletis balloon, a low compliance rather than high pressure balloon, has improved dilatation efficiency and may change the workflow in the management of AV access circuit stenoses. Now, finally, what about patients with central vein occlusions? This was a fascinating case report I saw recently at the LINC meeting from Thailand. Patient who had a right AV graft with right arm swelling due to central venous occlusion, got access from the graft and also from the right femoral vein, and got wires and catheters through the occlusion into the soft tissues in the supraclavicular fossa, deployed 2 snares, then percutaneously passed a 21 gauge needle through the snares, passed a wire through that to get through and through wire access, could then dilate the tract, put a VIA-BARM graft in, and had a functioning central venous extra anatomic occlusion. One other extra anatomic way of dealing with central venous occlusions is the surfacer inside-out system from Bluegrass, where the system is delivered entirely from the femoral venous approach and has a system that allows targeted navigation through to an exit point in the skin. So it has a catheter that traverses the occlusion. It has a needle guide that can be steerable, and then a needle wire passes through the skin. So, excuse me, if we have a look at this movie, we then pass the surface catheter system through the occlusion, and then we have the needle guide deployed, and then the needle wire passed through, and this is then retrieved, and a central venous catheter delivered. The early results with this system are promising, with a high success rate and no serious complications. So I hope this presentation outlines some interesting and new vascular access issues. Thanks very much for your attention.